Chapter 8, Lecture Outline. Chapter 8 deals with the skeletal system. I'm not going to cover the entire chapter because there's only a little bit on your second lecture exam. However, this chapter is really comprised of both of your upcoming lab exams on the skull as well as the bones. If you look at page, of course, this is on page 231 of your textbook. They're showing you there are two regions of the skeletal system. You have the axial skeleton, of course, it's color-coded in beige. That's the central part of your body. It's called the central supporting axis of the body, which consists of your head, your neck, your torso, the skull bones, or your vertebrae, if you want to look at it that way, the sternum, the ribs, the sacrum, and of course a little bone just below the mandible called the hyoid bone. The appendicular skeleton, on the other hand, is green. Of course, appendicular simply means appendages, or your upper and your lower extremities, which consist of your bones of the upper arm, the humerus, the radius, the ulnar, the carpal bones, your metacarpal bones, and your phalanges. You also have the pectoral girdle. There are three bones that form the pectoral girdle, the ilium, the ischium, and of course the pubis. So as you can see, the pelvis, that's your hip bone, and of course your sacrum. It's called the sacroiliac joint because the sacrum, which is the distal part of the vertebrae, or attached to your lumbar vertebrae, of course, is attached to the ilium, which is that large green flared part, which are your hips, which makes it the sacroiliac joint. If you look at your lower extremities, of course, you have your femur. We know it's the weight-bearing bone of the body. It's the longest bone in the body. Your tibia and your fibula, as well, your metatarsal bones, your phalanges, and of course your tarsal bones make up the appendicular skeleton. One thing that you do need to remember is that babies, there are 206 bones in the body. However, babies during birth, babies, of course, they have more. They have 270 bones. And we talked about in chapter 7 bone formation by endochondral ossification. And remember that some of the bones in a baby at birth still has not transitioned from cartilage to bone, which is why they actually have more. For example, your patella, which is also called your kneecap, of course, in infants, that bone does not completely ossify or until around the age of 3. I think your textbook says 3 to 6 years old. Also, the coccyx, which is your tailbone, that bone is often fractured during childbirth, and it's also fractured due to if you fall really hard on your butt. But that bone, I think, fuses around the age of 20. So sometimes it may look like, well, in kids, they don't have the transverse lines. When you get farther back into the chapter and they start showing you the individual bones, you can actually see that those little transverse lines that will appear once the bone has completely fused. The sacrum, it starts to fuse around the age of 16, and of course, is not fully formed into bone. By the age of 26, it should be fully ossified. So that's why you have the 270 bones, the ilium, the ischium, and the pubis. Also the cranial bones in babies. Of course, you have little spaces between your parietal bone, your temporal bone, the occipital bone, and the frontal bones, which are called fontanelles, I think, which is on your study guide. That's because those cranial bones have not completely fused at that time. So here you have extra bones that develop, 206 in the adult skeleton, 270 at birth, but number decreases with what? Fusion, or as the kid ages. Bone markings, which of course is very important. ridges, spines, bumps, depressions, canals, pores, slits, cavities, and of course articular surfaces. Those bone markings are very, very important because this is where muscles attach by way of tendons. You have a foramen, which is a little hole in the bone. Muscles, nerves, and blood vessels, of course, pass through it. So those bone markings are really, really important. If you look at table 8.2, which is in your textbook on 232, they have, of course, the term, the articulations, extensions and projections, depressions, passages and cavities, and they have descriptions and examples for each one of them. Of course, ways to study the bone. It's really, really important to study an articulated skeleton prior to studying the disarticulated bones, because the articulated skeleton, which is on page 231 of your textbook, they're also in the anatomy lab. Those are all the bones that are held together by wires and rods. That means all the bones. So it kind of shows you, if you're not familiar with all the bones in your body, you may want to start there before you look at your disarticulated bones, because they're going to be taken apart when you guys get your test. So you're going to have to, you can't be calling the femur the humerus, which is oftentimes what students do. They get some of those bones confused. They're calling the radius or the ulna the fibula. Of course, that's incorrect. So always start with the articulated skeleton and kind of work your way down to your disarticulated bones. But when we're studying in the lab, you guys are going to be studying the disarticulated bones, because those are the bones that will actually be, that's the way your lab practical will be set up. So that's important. There's 22 skull bones. They're held together by joints called sutures. They have a nice picture in your textbook showing the cranial cavities, the brain, which is your brain case, your eye socket, nasal cavity, oral, which means buccal. This is on page 236 of your textbook, figure 8.7, major cavities of the skull. And of course, you have 4 paranasal sinuses, which is very important too. Figure 8.8 of your textbook is showing you your 4 major sinuses. Your sphenoid, the frontal sinus. Those of you, around the corner, well, during the spring, of course, I have sinus infections, and I get really, really bad headaches. So sinuses are kind of like little air pockets that we have. And of course, they're the ones that air has to travel through, because they have the little pockets. So oftentimes when I get the sinus headache, there's like pressure behind the eyes, and of course, in other words, the sound can't pass through the sinuses. If you look at the frontal, that's your frontal. The ethmoid sinus, of course, is like between the orbits of the eyes. And of course, you have the maxillary sinus, which of course, that one expands with age. So those are the sinuses, of course, they get inflamed. You get the nasal discharge when you have sinus infections. And oftentimes when you have a cold or the flu, you have that nasally sound coming from your voice. That's because, as I stated earlier, you have little air cells, or I call them air pockets. The sound can't pass through those little air cells or pockets. And of course, your voice sounds muffled. So the purpose of your sinuses really is to lighten the skull bones. The cranial bones, cranium, you have so here they are here. Frontal, sphenoid, foramina, of course, that allow passage for nerves and blood vessels. And like I said, the sinuses are lined by the mucous membrane and are air filled. And of course, acts as a chamber that adds resonance to the voice, and it lightens your skull. Here's your cranium, or the cranial bones. The cranium, of course, is called your brain case, or the skull bones. So they're showing you how the brain sits, and there's several lobes of the brain. You have your frontal lobe, your temporal lobe, and your cerebellum, and they're showing you a lateral view. The base of the skull, of course, is really the floor, and the part that sits on top, which is called the calvaria, is your skull cap. So there are little meninges, which are membranes that we're going to talk about later in the semester, that separate the brain from the bone. So the meninges actually protect the brain, which covers it, protecting it from the bones that make up the skull, or the cranial bones. You have your dura mater, which is your thickest, the arachnoid, and your pia mater or mater. There are actually 3 of them. So you have one frontal bone, 2 parietal, 2 temporal, 1 occipital, 1 sphenoid, and 1 ethmoid. The frontal bone, of course, the orange part that you see in your textbook, that's simply just your forehead. The little smooth part just between the supraorbital margins of the eyes, of course, is called your glabella. You have a supraorbital foramen, which is in that picture. I see the supraorbital margin. Supraorbital foramen, of course, is a little hole that's on the supraorbital margin. You also have an infraorbital foramen as well. So, like I said, when you have a foramen, nerves, arteries, blood vessels, veins actually will pass through those. And your frontal bone, of course, consists of your what? Your frontal what? Sinuses. I don't know where that bone is in this book. Here you have your parietal bones. Both of those pictures are on your exam, your first lab exam. The parietal bones, of course, is on page parietal bone. Page 238 of your textbook, you have your parietal bone. Now, there are 4 forms most of the cranial roof. That's the roof, which is the top of your head or the skull, and it kind of goes down to the lateral walls. It kind of connects with your temporal bone, as you can see, which is our purple bone. There are 4 sutures for the parietal bones. Sutures, of course, we know are immovable joints to hold the bones together. You have your sagittal suture. If you look at figure 8.6, sutures, they look like little zigzag lines or wavy lines. So right down the middle at the roof of the skull, you have your sagittal suture, which of course holds the right and left parietal bones together. You also have your coronal suture, or the frontal suture, that actually connects the frontal bone with your parietal bones. Posterior, of course, you have your lambdoid. The lambdoid suture, as you can see, is right above the occipital bone, which of course is in green, and it kind of connects the occipital bone with the parietal bones. And of course you have your squamous sutures, which you cannot see. Well, you can see in the top picture, figure 8.4, squamous suture. It's also called the temporal suture because it's right above the temporal bone, which is that purple bone that you see. And of course you have those temporal lines for the attachment for the muscles, which one is called the temporalis muscle, which of course is one of your chewing muscles or one of the muscles of mastication. So that's the parietal bone. Temporal bones, of course, page 239 is giving you this one right here is sort of the most complex because there are a lot of different parts to it. You have your squamous part, your tympanic, and your mastoid part. They form the lateral walls, part of the floor of the cranial cavity. So they're showing you the 4 parts. One of it's called the temporal bone. The name is a derivative because first signs of gray hair often occur at the temple over time. You have your squamous part, which of course you have your squamous suture right above that. The zygomatic process, if you look at the picture to your left, that little thin bone that you see that's connecting your zygomatic bone or your cheekbone, which is in blue, is connecting. It's a bridge between the zygomatic bone and the temporal bone. That's your zygomatic process. So it forms part of the zygomatic bone, which is your cheekbone, and the mandibular. You also have the mandibular fossa. The mandibular fossa, of course, is a little hole. If you look at your mandibular condyles, they will actually insert in the mandibular fossa. Of course, if you open and close your mouth, you can actually feel, it's called the temporal mandibular joint. Temporal mandibular joint. We're going to talk about joints in chapter 9. TMJ, of course, often occurs there. If you open and close your mouth and you put maybe your index finger or something on both sides of the temporal bone, you can actually feel that joint moving between the mandible and the temporal bone. And of course, it's if you hear it clicking or popping, often that's a sign of TMJ. The tympanic part, you have an external and an internal auditory meatus or acoustic meatus. So of course sound travels through there. You have the styloid process, which is that little pointed part. The styloid process was taken from the hence the stylus, which is a writing pen that was used by the Greeks. So muscles of your tongue, your pharynx, and your hyoid bone, of course, actually will attach there. The mastoid part, the mastoid process is that little bump that you see coming from the temporal bone. If you take your index finger and palpate right behind your ear, you can actually feel it. This one as well has little air sinuses or pockets that actually communicate with the inner ear. You can actually get mastoiditis there, which of course is inflammation, just simply inflammation of the mastoid process. It's very, very painful. You get earaches, there's swelling behind the ear. And of course, if pathogens are involved, that's when you get the inflammation. It can erode the bone and of course spread to where? To the brain. So the mastoid process is the most important part of this particular bone, I think. Of course, you have your notch. Then you have your foramen and the stylomastoid foramen as well. The mastoid foramen and the stylomastoid foramen. The petrous part, of course, that's the floor of the temporal bone. You have that's to your receptors for hearing and balance are there. You have your internal auditory meatus, which is the opening for cranial nerve 8. Cranial nerve, of course, you have 12 of them. That's actually 2 letters, CN, that's followed by a Roman number or Roman numeral. And this one is cranial nerve 8, which is the vestibulocochlear nerve. That's the nerve for hearing and, of course, balance. And, of course, if that nerve gets severed or if you have complications with that nerve, you can have the dizziness and you also can lose your balance as well. So in your textbook, page 239, under number 4, it says the vestibulocochlear nerve, which is, of course, is italicized, carries signals for hearing and balance from the inner ear to the brain. So that's cranial nerve 8. You also have a carotid canal. That's a very, very important canal because your carotid artery actually travels through there. Oftentimes, if you're lying on your ear on a pillow, you can hear that pulsating sound. That's the carotid artery that's pulsing when your ear's on the pillow. Like I said, the carotid artery passes through there. A major blood supply to the brain, carries a huge amount of blood to the brain. You also have the jugular foramen. Of course, your jugular vein passes through that, which is on page 240 of your textbook. So the blood, a huge supply or amount of blood drains from the brain, or travels from the brain to the rest of the body. So it carries a large amount of blood actually from the brain to the heart. And of course, if that vein, of course, gets severed, of course, death will occur immediately. You have an internal jugular vein. You also have an external jugular vein. The external jugular vein collects blood from the outside of the skull, but your book only talks about the internal one because that one carries a little bit more weight than the external jugular vein. The occipital bone, let's see what you need to know from there. There you have your hypoglossal nerve, which is cranial nerve 12. Okay. That's the nerve that goes to your tongue. It innervates your tongue to allow it to move. Of course, if that nerve gets severed or damaged, you will not be able to move the tongue or protrude the tongue. That's your hypoglossal nerve. You have your external occipital protuberance, which of course is on your first lab exam. That's that little bump or notch that sits at the base of the brain. You also have ligaments that attach there. You have superior and inferior nuchal, a nuchal line, or you have nuchal ligaments there as well, which actually connects the skull to your vertebral column, which is very important. So you have your superior and inferior nuchal lines. Your neck muscles will actually attach there. So, and of course, another important aspect of this bone, of course, is your foramen magnum, the opening for your spinal cord. Remember, a foramen, of course, is just a big hole. You can see your foramen magnum on that picture, the inferior view, where you can actually see that's the part the spinal cord will insert there, and of course it's going to attach to the dura mater or the brain stem. It also states that an important consideration in head injuries is swelling of the brain. Since the cranium cannot expand, swelling puts pressure on the brain and results in even more tissue damage. Severe swelling can force the brainstem out through the foramen magnum, usually with fatal consequences. So oftentimes, because of the cranium or the brain case, the brain, when it swells, of course, typically, if doctors can't stop the swelling, like I just stated, the actual brain stem, which is at the base of the brain, will actually come out through that hole, which is your foramen magnum, which puts pressure on your spinal cord and, of course, can lead to death as well. So you have your little occipital condyles. C1, actually, the occipital condyle sits on top of C1, which is the first cervical vertebrae. So that's the part. We're going to talk about C1 and C2 a little bit later. Knobs resting on your spinal column. The first bone that makes contact with those knobs, of course, will be C1. On page, this way here, turn over to page 250 of your textbook. If you turn to page 250 of your textbook, figure 8.23, they're showing you articulated vertebrae. And of course, you can see your superior articular facets. Those little occipital condyles will actually sit on that. C1, of course, is called your atlas. C2 is called the axis, since we're over here. So C1, of course, the atlas, okay? So the occipital condyles sit on top of that. So when you're nodding your head up and down, up down, up, down. Of course, your occipital condyles are rocking back and forth on the superior articular facet. Okay. And of course, C1, which is your atlas, sits on top of C2. So when you're rotating your head, of course, left, right, as if you're saying no, of course, that's because your C1 and C2 are actually pivoting around each other. And it's called the atlantoaxial joint, chapter 9. A joint is simply where you have two bones that meet. In this case, it's going to be your atlas and your axis, which is why it's called the atlantoaxial joint. Of course, these are the two bones, only two bones in your body, vertebrae, that have a specific name. Of course, it's going to be your atlas and your axis. You need to be familiar with the way how they differ from each other. If you look at C2, your axis, you can see that it has a dens. Okay, so the dens, of course, is a little knob. It's also called the odontoid process. That's a really distinctive feature, as your book talks about, of C2 of what? The axis. So C2, you're gesturing what? A no. And of course, C1, the occipital condyles will rock back and forth on top of the atlas, which is C1, allowing you to say no, and C2, yes, and C2 allows you to say no. Okay. So the two bones will actually fuse together because there's no fusion there between C1 and C2. It's not very smart to shake a baby because the fusion of those two bones is incomplete. And of course, the shaking of a baby can cause the dislocation of the skull. Okay. So it doesn't completely ossify, or they don't fuse together. Your textbook talks about until the age of 3 to 6 years old. First year of life infuses with the axis by the age of 3 to 6 years. Okay, so that's very important. Atlanto-occipital joint, atlantoaxial joint, page 249 to 50 of your textbook. So a lot of this stuff I'm just going to bypass because I'm just kind of talking. Sphenoid bone, of course, that one, that's a pretty good one. Here you have the foramen rotundum, the foramen ovale, the foramen lacerum. You can actually see two of them, 1, 2, 3. Rotundum, the ovale, your spinosum. In the sphenoid bone, if you look at the superior view of the cranial floor, that's that blue bone. Okay. And you can see the little holes for each one of those. You have your medial and lateral pterygoid plates. Your medial and lateral pterygoid bones will actually attach to, they're part of the plates of the particular, of that particular bone. Kind of looks like a butterfly or has little bat wings. I think your book associates it with having looking like a bat or something because they have the wings, the greater and lesser wings. And you also have your sphenoid sinuses there as well. The sphenoid bone, greater and lesser wings, which give the bone as a whole a ragged moth-like shape, which is on page 240, first paragraph of your textbook. You have the optic canal. Yep, your optic canal, of course, is a part of the sphenoid bone. Cranial nerve 2, which is your optic nerve, of course, passes through there. The sella turcica, which is right there in the center of the sphenoid bone, of course, that's where the you have a hypophyseal fossa. The pituitary gland actually sits in there, which is important. And so that's pretty much the important part of this particular part. Trigeminal nerve passages for the passes through the foramen rotundum and the ovale. Trigeminal nerve, which is cranial nerve 5 actually. The ethmoid bone located between your eyes, as you can see, and it kind of goes down into the upper part of the nasal cavity. So it's the medial wall of the orbits, which is like the medial portion of your eye sockets, and of course the roof of what? Your nasal cavity. The olfactory foramina, of course, the olfactory nerve passes through there. Olfactory nerve. A lot of these nerves are located in that table on page 237 of your textbook. Of course, the olfactory nerve, of course, is your first cranial nerve. Carries a sensation, or is the nerve that's responsible for smelling. So you have the olfactory bulb, a pair of olfactory bulbs of the brain concerned with the sense of what? Smell. That's number 2 on page 241 of your textbook. The crystal gali, of course, is important as well. One of your meninges attaches there, which is your dura mater attaches there as well. And of course, you have your ethmoid sinuses, which are actually here as well. Some more important cribriform plates, the olfactory foramina, which is important, ethmoid cells, where your ethmoid sinuses are. There are 3, your superior and middle nasal conchae. There are actually 3 of them. That's important to know too. You have a superior, middle, and inferior. The inferior one, of course, is studied as a separate bone, as you can see, and that's the largest of the 3. Those 3 bones are very, very important because what they actually do when air comes into the nasal passages, of course, those bones are responsible for cleansing or cleaning the air. So particles in the air, they have mucous membranes, of course, are a part of these 3 bones, and when air comes into the nasal cavity, well, it has to hit the mucous membranes of these 3 bones, which is a part of the ethmoid bones, which will actually cleanse the air, it warms the air and humidifies it before it actually reaches the lungs. So it kind of creates what you call, as some anatomy textbooks call, turbulence, where they will actually spin, the air will actually spin against the mucous membrane. The air movement is slowed, which provides time for the warming, the humidification, the removal of dust before it actually reaches the lungs. So they ensure that the air contacts the mucous membranes that cover these bones, which cleanse, humidify, and warm the inhaled air before it reaches the lungs. Damage to the olfactory nerve, just remember, read clinical application, injury to the ethmoid bone. Of course, anosmia can appear if you have like a blow to the head and the olfactory nerve is damaged. It's going to interrupt your sense of smell, called anosmia, an irreversible loss of the sense of smell, and a great reduction in the sense of taste, most of which depends on what? Smell. So what can happen, because it sits at the roof of the nasal cavity, sometimes when people get, the nasal bone gets fractured, or an upward blow to the nose, little bone fragments can travel up through the cribriform plate, to the brain or the meninges, and of course, cerebrospinal fluid, which is fluid that's found in the brain, can actually leak, and it can lead to some form of infection, which can actually spread. So that's important. Facial bones, of course, you have 14 of them. They actually form the, it's called like the front porch of the other bones. Supports your teeth, gives shape to the face, forms a part of the orbital and nasal cavities, provide attachment for muscles of facial expression and mastication. Of course, you have 2 maxillae, 2 palatine, 2 zygomatic bones, 2 lacrimal bones, nasal, inferior nasal concave, vomer, and 1 mandible. So that's where the 14 comes into play, along with the 8 cranial bones, which will actually give you a total of 22. The maxillae, of course, is the largest facial bone that you have. That's on page 243 of your textbook. The maxillae, which is there are 2 of them. If you go back, how many do you have? 2. So there's a little intermaxillary suture that's connecting the right and left maxillae, okay, where they actually meet. Alveolar processes, those are kind of like little, well, they're points. If you look between your teeth, the little bone between your teeth that's projecting down, those are called your alveolar processes. The actual socket that holds the tooth is called the alveolus. Also in the alveolar processes, you have your periodontal ligament that will attach there too. If that periodontal ligament, of course, starts deteriorating over time, that's when your teeth get really, really weak and they will actually fall out of the alveolus, which is your tooth socket. Bone resorption, they talk about resorption over here, page 243 of your textbook. Make sure you read that. Okay, when you have a tooth extracted, of course, there's a little hole there. And then over time, that little hole becomes a smooth surface. That's bone resorption. Cleft palate and cleft lip, of course, during 12 weeks of gestation, the palatine process is supposed to actually fuse at the intermaxillary suture during 12 weeks. If the fusion does not occur, of course, it's going to leave the cleft palate and the cleft lip in babies, but it can actually be repaired or surgically repaired. But you can actually kind of tell when kids have had the surgery. If you just look at their nose, the distal portion of their nose and the maxillae, you can see where there was that cleft palate or lip, but of course they had the surgery. So 12 weeks of gestation, failure to join results in a cleft palate accompanied by a cleft lip, which is lateral to the midline. A cleft palate and lip can be surgically corrected with good cosmetic results, but a cleft palate makes it difficult for an infant to generate the suction needed for nursing. So it actually can have a negative impact on the sucking reflex babies need when they're actually nursing. So that's the maxillae, which is the largest. Here's the palatine process. You have a hard and a soft palate. If you take your thumb and put it at the roof of your mouth, the anterior portion is hard, but if you wiggle it all the way to the back, of course, near your throat region, of course, the palate gets a little bit hard. The palate, of course, allows us to chew and breathe at the same time. You have your palatine process. You have a little incision called the incisive foramen. And, of course, you have your maxillary sinuses that are here. The maxillary sinuses are actually your largest of all of the other sinuses, your sphenoid, your frontal, as well as your ethmoid. Palatine bone, of course, is just an L-shaped bone. They don't have a lot about that particular bone, which is on page 243 of your textbook. Of course, you have your zygomatic bone. That's that blue bone that you see, figure 8.4a. That's your cheekbone. You have a zygomaticofacial foramen. Nerves and blood vessels to the cheek travel there. So there's an arch, a zygomatic arch here as well. So the zygomatic arch is formed from your temporal process of the zygomatic bone and the zygomatic process of your temporal bone. That's your zygomatic process. They call it an arch as well because there's a bridge between the temporal bone and your zygomatic bone, which of course is called the zygomatic arch or the zygomatic process. So little paragraph on that page 244 of your textbook. You also have the lacrimal bone. That's the smallest of all the bones of the skull. It forms like the medial walls of the of your eye socket. You can see it in red in that picture, figure 8.4a. It also has a little sac, which is called your lacrimal sac, where your tears are actually housed there. So the tears will collect in a sac, and of course they will actually drain into the nasal cavity when you're crying, which is why you have the runny nose. So not only are the tears formed and rolling, on the surface of your face, so the tears has to travel through a little gland or duct, okay, before they actually reach the surface of the face. And of course the tears can also drain into the nasal cavity, which of course gives you the runny nose. The nasal bone, as you can see, forms the bridge of your nose. They're showing you the nasal bone in purple. And of course, as you can see, the nasal bone, your nose, is medial to your eyes. Your eyes are not superior to your nose, because you can see that purple portion is going all the way up near the supraorbital margins of both the right and your left eye sockets. Of course, this bone is often fractured when there is a hard blow to the nose. Okay. So it says if you palpate the bridge, and you can easily feel where the nasal bone ends and the cartilage where begins. So the tip of your nose, it's kind of soft. That's where the cartilage is. But if you go to the medial part of the eye and just work your way down, it's hard. The bones are hard. And you can tell where the nasal bone ends and the cartilage, which is your tip of your nose, actually begins. Here's that inferior nasal concha we talked about earlier with your superior and middle. This one is the largest of the three. You have the vomer, of course, the mandible, which of course is my favorite. It's the strongest bone of the skull. This bone is actually on your first lab exam. This is the bone that actually moves. The maxillae doesn't. So you have alveolar processes over here too between the teeth. They're actually showing you over here, which is good. Alveolar processes between the teeth that supports what your lower teeth. Muscles attached there. Some of your chewing muscles will actually attach there. You also have the condylar process. Your temporalis muscle actually will attach to the condylar process. Those little mandibular condyles will attach to the temporal bone. We talked about those earlier. And there are three parts: the ramus, the angle, and of course your body. You also have the mental symphysis. The mental symphysis, of course, if you look at the mental protuberance in babies, it kind of looks like they have two mandibles, because that part, of course, the mandible has not completely ossified yet, and it looks like they have a right and left side. The mental protuberance, of course, is just the point of your chin. The mental foramen carries sensory information from the lips, your chin, and of course to your brain as well. You also have a mandibular foramen, which is the passageway for nerves and blood vessels. Of course, this is where dentists often inject lidocaine or here in that particular foramen to deaden the teeth because prior to extracting the tooth. So you have to, when your dentist asks you to open your mouth wide, because the mouth has to be opened very, very wide. If not, he'll miss the mandibular foramen because that needle must be positioned a certain way. So that trigeminal nerve, which branches out, cranial nerve 5 branches out to all the nerves of the lower teeth. And of course, the mandibular fossa or foramen, of course, is used as the point where dentists inject the lidocaine. So, mandibular foramen, the nerve and blood vessels that supply the lower teeth enter this foramen and then travel through the bone of the mandibular body, giving off branches to each tooth. Along the way, your dentist commonly inject lidocaine near the mandibular foramen to deaden sensation from where? Your lower what? Teeth. Okay, so mental symphysis, mental foramen, nerves and blood vessels that supply the chin or your lips as well. You have the mandibular foramen, nerves and blood vessels of your lower teeth. You have your 3 parts. There's the condylar process. You also have your mandibular condyles, as I stated earlier, which articulates with the temporal bone, forming your temporal mandibular joint. What is a joint? That's where 2 bones will meet. In this case, it's going to be the mandible and your temporal bone. And of course, the coronoid process. I think I said the condylar process, but the coronoid process, that's where your temporalis muscle will attach there. The hyoid bone, of course, these are bones associated with the skull. The hyoid bone, as you can see, is a little slender shaped bone. Doesn't attach to any other bone or articulates with any other bone. Of course, this is the bone that's often fractured during strangulation. That's evidence of strangulation, and forensic scientists will do an autopsy on this particular bone if they suspect someone has been strangled. Okay, so I'm going to end right here. I'm going to pick up with the skull and infancy. So I've talked about the skull bones of the adult skull, and of course I've talked about the facial bones of the adult as well. So we're going to pick up here. This is on your study guide for lecture exam 7, 8, and 9, fontanelles. Make sure you read about that. Okay, so we're going to end it here. Stop the recording.